It's rare for shingles to be mild pain. I think in most cases it would be at least moderate and more often severe. I think one of the problems with shingles is a lot of the people don't know that they have shingles. For a lot of younger people in particular, they'll have no experience with it. So often their first port of call might actually be to go to the pharmacist. So often when patients present with a new rash, they might go to the pharmacist first to try and get something there. The other issue is that, for example, if a patient gets the rash on a Sunday, trying to get access to a GP within 24 to 48 hours can be difficult. I think that those issues do create a little bit of a barrier to patients getting access to a doctor to get a prescription to get the oral antivirals within the first 48 hours. It's a difficult situation when patients present outside that initial 72-hour window, and certainly when they're presenting more than a week after the shingles has began. Really the main option you've got there is pain relief. So that's when you're looking at paracetamol, anti-inflammatories, neuropathic pain relief. There's no role for antivirals, at that stage. So I guess one of the main challenges that you might have in treating pain that's associated with shingles is that a lot of the time patients who get shingles maybe have other health problems. They might have impaired kidney function or impaired liver function, which means that they are more likely to get side effects with oral medications, and that they're also probably more likely to already be on other medications. And as soon as you add in more medications, there's then an increased risk of drug interactions. So you've got to be very careful when you're prescribing in this patient group, because you can inadvertently cause harm by prescribing painkillers. So there are obviously nerve painkillers that we can use, but these medications aren't without side effect or risk, and we've got to be sure that they're not going to interact with the patient's other medications, and we've also got to be sure that the patient's got sufficient kidney and liver function to be able to process these medications safely. I think when I was approached about getting involved, the thought of having a topical agent that we could use that would be safe, that would reduce pain, would be quite an exciting thing. Generally speaking, topical agents tend to be better tolerated than oral agents with less risk of sort of systemic side effects. So I think if we can go for a topical option, that's always going to be one of the things that we would do first if we're able to. So looking at the data that we've got from the initial trial, thankfully there weren't any sort of significant or serious adverse effects reported, which is excellent. And what it looks like is that the product reduces pain, and it also interestingly looks like it probably has a positive effect on how pain impacts on our ability to engage with activities of daily living. So go to work, go to gym, go and see friends, things that we would normally do, which I think was quite a positive thing. I think if the data is replicated on a larger scale, and from the phase 2 we're able to see statistically significant, data which reinforces that data that we found in the first phase of the trial, I think that's going to end up changing clinical practice potentially. I think you're then looking at a topical agent which might become standard practice when treating patients with shingles. And what that will hopefully also do is open up the door to an effective medication that can be used safely to try and help alleviate pain for a lot of patients in whom oral medications might be high risk or contraindicated.